Good afternoon, and thank you for joining us today for today's webinar entitled, One is a Problem, Two is an Outbreak, Detecting and Responding to Outbreaks in Long-Term Care Facilities. My name is Wanda Lamb, and I am today's moderator. This presentation is provided by the North Carolina Statewide Program for Infection Control and Epidemiology, also known as SPICE, and funded by the CDC Infection Control Assessment and Response ICAR grant. The North Carolina initiative was a 3-year collaborative effort between the North Carolina Department of Public Health and SPICE. Infection control program evaluations were provided to 113 long-term care facilities across the state. Today's topic was identified as one of our gaps during our long-term care assessments. To learn more about the grant, please visit our website at spice.unc.edu. All lines have been muted for the presentation. If you are joining us via phone, please mute your phones now and do not place the call on hold. Questions will be addressed at the end of the presentation. You may either type a question in the chat box by hovering over the icon at the bottom of your screen, or unmute your phone during the question and answer session at the end of the presentation. This webinar is being recorded and will be available at a later date on the SPICE website, along with the presentation slides. A brief evaluation will be sent out to all registered participants for program feedback. Continuing education credits will not be provided for this live webinar. However, you will be able to print a certificate of attendance after you complete the evaluation. Today's speaker is Jennifer Mafarquhar. Jennifer is a Centers for Disease Control and Prevention, CDC Career Epidemiology Field Officer assigned to the North Carolina Department of Health. In her role, she provides leadership, guidance, and direction to strengthen the statewide communicable disease outbreak response and serves as the Healthcare Associated Infections, the HAI Program Prevention Team Lead. Jennifer received her Master's in Public Health and a Graduate Certificate in Community Preparedness and Disaster Management from UNC Chapel Hill, and a Bachelor of Science in Nursing from Cedarville University. She has maintained certification in Infection Control and Epidemiology since 2000. Jennifer, thank you for joining us, and we look forward to your presentation.
Good afternoon. Thank you for the opportunity to speak with you today. Objectives for today's session are listed here, and they include: describe the legal framework here in North Carolina for communicable disease surveillance, investigation, and response, review historical outbreak surveillance data, discuss when to call public health, describe specific organisms and outbreaks in long-term care settings, and discuss the public health role during investigations. First, I will begin with the legal framework for public health investigations here in North Carolina. Public health laws and rules are outlined in what we call general statutes and administrative code rules. This framework gives authority to the health directors in each county and at the state level to conduct surveillance for diseases and outbreaks, investigate reports of diseases and outbreaks, as well as institute control measures to prevent the spread of illness. The next two laws establish the legal authority and responsibility for public health action to the local health director. The take-home points are that the local health director has the responsibility and obligation to investigate cases of communicable diseases and conditions, and also to ensure that control measures have been given to prevent the spread. In the course of this investigation, physicians and others are required to provide copies of medical or other records and also give control measures. And all persons shall comply with provided control measures, including submission to examination and tests. This next law is from the North Carolina Administrative Code. It again establishes the responsibility and obligation of the local health director to investigate cases of communicable diseases and conditions, provide appropriate control measures, and ensure that control measures are being complied with. These laws mainly deal with cases of communicable diseases and conditions that are considered reportable in North Carolina. However, I would like to highlight that the administrative code here also extends to outbreaks of diseases and conditions that are not required to be reported, but which do represent a significant threat to the public's health. The local health director also has the responsibility and obligation to provide appropriate control measures in these situations as well. Examples of these may be an influenza or norovirus outbreak in a healthcare facility. Neither of these are reportable, but do represent outbreaks that pose a threat to the public's health. So this is the law that specifies what communicable diseases and conditions are reportable in North Carolina. There are currently 74 reportable diseases and conditions, but it does change sometimes on an annual basis. The timeline for reporting varies between immediately to within 7 days. The law also specifies reporting requirements for laboratories. Additional laws, which I will not go into, specify who's responsible for reporting communicable disease information. So next, I'd like to spend a few minutes discussing the steps of an outbreak investigation, highlighting those most important for use in long-term care settings. Additionally, each of you should have a written policy in place for outbreak response, and I will make some suggestions for components of this plan. So, as just mentioned, you can call us with any case or suspected case of a reportable disease or condition. Again, the list of these reportable conditions can be located at the website listed here. Another time to call is when any disease is above what we call above baseline, or more than what you would expect to see. For example, if you normally see 3 or 4 residents with a respiratory illness during the month of July, and you now have 10, this is an increase over what you would expect to see. And again, you could always call us if you're not sure if a disease is above baseline. So we hear the term outbreak. What exactly does this mean? As just mentioned, an outbreak is any increase in disease above what you would normally expect to see. And again, if you aren't clear about what is normal, please call us. As a general rule, in facility settings, an outbreak is defined as 2 or more individuals with the same illness. However, there are exceptions to this rule, and for certain organisms, such as specific multi-drug resistant organisms with a novel mechanism of resistance, or Ebola, 1 case would be considered to be an outbreak, as we would not expect to see any of these. So listed on this slide are the 10 steps of an outbreak investigation that we in the North Carolina Division of Public Health follow during public health investigations. You may see variations on this list during your career, but the important point is that you have a set of steps and a plan to follow, and that you approach outbreaks systematically. For use in your daily practice, it isn't necessary for you to remember and list these steps, but I would like to highlight the first 2. Specifically, identify your resources. Who will you call and when? You need to have these elements documented in your infection prevention and outbreak response policy. So when you suspect an outbreak, there should be a few individuals or agencies included in your written policy that serve on your outbreak response team. These include your supervisor or a manager and your local health department communicable disease nurse. These persons should be at the table helping to assess the situation and determine if in fact an outbreak exists and assisting with next steps. Other persons or organizations available to assist and serve as resources include us at the North Carolina Division of Public Health. We have a 24/7 epidemiologist on call available to respond to questions, and also the North Carolina statewide program for infection control and epidemiology, as well as your local hospital infection preventionist. So what does public health do during investigations? When public health is called for a suspected outbreak, we will first ask questions to determine if in fact you have an outbreak. We will look at specific data. We'll ask you to review medical records. We'll also conduct an additional clinical investigation, which includes looking for other cases who are ill or who have become ill, and we call this case finding. We will also conduct interviews. We might speak with residents, but we'll speak with certainly the healthcare providers themselves. We may also request specimen collection and conduct testing. We'll also look at the environment and conduct an environmental assessment or environmental investigation to determine if we can, in fact, identify a breach that might have occurred that led to this outbreak. We also assist with implementation of control measures, and we'll do this at various stages throughout the investigation, again, because we want to assure that the outbreak is stopped to prevent further illness from occurring. And lastly, we will also assist with patient, family, or public information and communication as needed. So when you call the Division of Public Health, here are some of the people with whom you might speak. This is my team, and we focus on healthcare-associated infections and multi-drug resistant organisms. It is composed of myself, the program director, a medical director, 3 epidemiologists, and a health educator. And hopefully coming soon, we will add a program manager. The formal surveillance for and documentation of outbreaks reported to the North Carolina Division of Public Health began around 2011. I'll present a brief overview of the past few years of data from 2014 through 2017. During the years 2014 to 2017, a total of 901 outbreaks were reported for an average of 225 per year. We actually anticipate that this number is much higher. As we know, reported outbreaks truly represent only the tip of the iceberg. On this slide, you will see a table on the left with 2 graphs on the right. The colors coordinate on the table and the graphs, with blue representing gastrointestinal caused outbreaks, red representing respiratory caused outbreaks, and green representing other causes of outbreaks, including scabies. Moving down the table, you see the type and etiology or suspected cause and year from 2014 through 2017. You will see that gastrointestinal illness accounts for about half, maybe a little better than half, of all outbreaks reported during this time period, with 80% of these caused by norovirus. Respiratory illness accounts for a little less than half of all outbreaks reported, with influenza contributing the most at 90%. And the graphs are a pictorial representation of the table. Continuing with the same time period of 2014 through 2017, the settings in which reported outbreaks occurred is demonstrated on this slide. The highlight here is that consistently over the past several years, the majority of outbreaks, approximately 72%, have occurred in long-term care settings. And in 2017 alone, of the 320 outbreaks reported, 239 occurred in long-term care settings. So I'm going to transition now to discuss a few types of infections that frequently affect long-term care settings. A single case of illness would prompt action, and 2 cases would likely be considered an outbreak. For the remainder of this presentation, I will focus on 4 different organisms. The first being Legionella. Legionella pneumophila is a bacteria that causes a respiratory illness called legionellosis. It is transmitted by inhalation of the bacteria in water that can be aerosolized from fountains, shower heads, and cooling towers, just to name a few. However, only some people will become ill when they are exposed. Risk factors for illness include older age, smoking, and underlying conditions that could compromise the immune system. A single patient with Legionella is considered a sentinel case. If this patient is a resident of a healthcare facility, including a long-term care facility, we would look for additional cases and implement some certain control measures. If there are 2 or more cases of Legionella in the same place at about the same time, then we do consider this to be an outbreak, and an outbreak investigation would be initiated. So next, I'm actually going to talk about a Legionella outbreak that are actually a set of outbreaks that occurred in 2014. During June through October of 2014, the North Carolina Division of Public Health identified 5 outbreaks of Legionnaire's disease, which is pneumonia caused by Legionella, at different long-term care facilities. Shown here on the slide is an epidemic curve, which is used to show the number of cases associated with an outbreak in a picture format. The number of cases is listed to the left of the screen on the y-axis. Time is shown at the bottom of the slide along the x-axis. So for this, we identified 23 Legionnaire's disease cases among 5 long-term care facility related, among 5 long-term care facilities. And each of the colors depicted on the slide correspond to 1 long-term care facility. While we received notification of these outbreaks between June and October, when we looked back in the medical records, we identified additional cases with onset dates as early as December 6, 2013. So one of the outbreak investigation steps is to conduct an environmental assessment, which means we visit the facilities, which we did for all 5 of these long-term care facilities. So some of the findings from these environmental assessments included that each long-term care facility did have water systems conditions favorable for the growth of Legionella, including areas of stagnation and less than optimal hot water temperatures. So this means that they were lower than the recommended minimal setting of 140 degrees Fahrenheit. 1 had 2 cooling towers on site. One of these long-term care facilities actually had a wing of the facility that had been unoccupied for several months, and maintenance water flushing of that section of the facility had not been routinely performed. This actually led to stagnation of the water and hence growth of Legionella. None of the facilities had a routine water system maintenance plan, and none had a healthcare facility Legionella prevention plan. Another step during outbreak investigations is to initiate control measures. Again, we do this at various times throughout the investigation. We will institute immediate control measures, and then throughout the investigation, as we learn more, we will institute additional control measures. So again, and this is because we want to prevent additional persons from becoming ill. So we recommended the following control measures for each of these facilities: to temporarily restrict tap water use, which means not running tap water at all in these facilities, installing 0.2 micron point of use filters, which is actually demonstrated on this slide here. We put these filters on sinks and showers to remove Legionella bacteria from the water. And after those have been installed, water restrictions could be lifted so they can once again use the tap water. Also, to conduct water system superheating by turning hot water tanks to 160 degrees Fahrenheit for 3 hours and then purging the water lines. And also conducting hyperchlorination. We recommended to maintain the hot water heater temperatures to at least the minimum required setting, which is 140 degrees Fahrenheit. We also recommended that these facilities consult with an environmental engineer to develop a plan for Legionella prevention and remediation as needed, and also to continue surveillance for cases of Legionnaire's disease. And lastly, to communicate this information with residents, patients, families, visitors, and staff. So in terms of prevention strategies, it's challenging to prevent all cases of Legionnaire's disease because Legionella bacteria, again, may be found throughout the environment and in water systems. So it is important for providers to be aware of Legionella and its related risk factors so that they can test for it and treat it. It is also important that people follow manufacturer instructions when using and cleaning respiratory therapy equipment, and that they do not use tap water in these devices. Another important prevention strategy for healthcare facilities in particular involves the development and implementation of water management programs to reduce the risk of Legionella in water systems. So what exactly is a water management plan? This is a formal written water, a formal written water management plan is actually now required by CMS for long-term care facilities. This plan consists of a written plan and policies to assure that water systems are implemented and maintained in such a way to reduce the potential for growth of Legionella bacteria and also reduce the exposure of persons to aerosolization of potentially contaminated water. This process should involve leadership, maintenance personnel, and someone who understands Legionella, such as a Legionella expert consultant. So my program developed a Legionella resource, which was actually released in January, and this resource is available on our website. So next, I will discuss Group A Streptococcus. Group A Streptococcus, or Group A strep, is a gram-positive bacteria that is commonly found in the throat and on the skin. So we frequently think of this as strep throat. Severity of illness can vary depending on the site of infection. Residency in a long-term care facility increases the risk of death for persons with with Group A strep. Between 1,100 and 1,600 people die each year as a result of invasive Group A strep disease annually in the United States. Long-term care facility residents are actually 1.5 times more likely to die from invasive Group A strep infections than the average population. And this equates to approximately 10 to 15% of long-term care facility residents who require Group A strep infection will die. So now I'm actually going to talk about another outbreak that occurred here in North Carolina. So in January of 2017, we received a phone call advising us that there were cases of Group A strep in 2 separate facilities in the same county in North Carolina. These were what we call sister facilities, as they were owned by the same parent company. In response, we looked back in medical records for 1 month to look for additional cases. Again, this is called case finding. We then asked the staff who might have had Group A strep symptoms, such as a sore throat, and we cultured any of those healthcare workers that were identified to be symptomatic. We also cultured any close contacts such of the residents, and that would be a roommate, and then also any healthcare worker who provided extended care, such as wound care or assistance of daily living. We then conducted active surveillance for 4 months following the last positive case, which means we continued to look for cases for 4 months. And we also conducted an on-site assessment for infection control. So when we conducted the site visit to observe infection prevention practices, we identified several risk factors for disease transmission. One of those would be wound care, conducting of wound care. And these individuals actually were reusing the same equipment on different patients. They were also not conducting hand hygiene appropriately. One other item that we did find was that staff were working while they were sick. So here is another epidemic curve, or EPI curve. The color red denotes association with facility A, and blue denotes association with facility B. So in summary, for this outbreak, we identified 24 cases, 10 from facility A, and this was a combination of residents and employees, and 14 cases for facility B. Again, a combination of residents and employees. 6 of these residents died, which means that 25% of those who became ill died. And this is substantially higher than the statistic that I just quoted to you a few minutes ago, which was 10 to 15% of long-term care facility residents would die as a result. So this is suggestive of the severity of illness that group A strep can cause. So a combination of our assessments, including on-site, laboratory, and also epidemiology, identified a substantial infection prevention gaps, again, as I mentioned to you a minute ago, with hand hygiene breaches, and again, also some of the lack of appropriate hand hygiene and other hygiene practices during wound care. We did also identify an employee that was shared between the two facilities. So prevention of group A strep. So key prevention measures include encouraging the facility to keep a sick log of healthcare workers and ask specific questions about group A strep symptoms such as sore throat and fever. And again, all symptomatic staff should be cultured during an outbreak. But again, strict attention to hand hygiene. This is vital for preventing the spread of group A strep. So next, I'll move on to discussing hepatitis B and C, as these are two of the most common pathogens associated with breakdown and injection safety, which I will discuss shortly. So hepatitis B is vaccine preventable, but unfortunately, there are approximately 850,000 to 2.2 million persons with chronic infections in the United States. Hepatitis B is also transmitted via blood and sexual contact and can also live in the environment, including on medical equipment, for more than 7 days. Hepatitis C is the most common chronic bloodborne infection in the United States, with 2.7 to 3.9 million people living with this disease. Most of the people living with this disease are what we call the baby boomers, individuals born between 1945 and 1964. This is not going away, and in 2014, there were an estimated 30,500 new infections. And so these chronically infected individuals serve as a reservoir for transmission if safe injection practices are not followed. So I'm actually going to move on and discuss an outbreak of hepatitis B. On Tuesday, October 10th, 2010, a county health department notified an infection preventionist at the local hospital of 4 cases of acute hepatitis. These individuals were residents of the same assisted living facility. We investigated using the following outbreak investigation methods. We conducted an on-site assessment looking at infection prevention practices, also conducted observations and interviews of staff and residents. We looked for additional cases, and we also conducted the testing, the serologic testing of all residents. We also reviewed hospital records and surveillance databases to see if we had other individuals who were infected that might be related to this outbreak. And then we also conducted a next step in an outbreak investigation, which is called an epidemiologic study, to look at potential healthcare exposures and risk factors. We actually identified 8 cases of hepatitis B. The average age was a little over 70 years old. 8 of these individuals were hospitalized. But what I would like to emphasize is that 6 people died. So we had a 75% mortality rate. So when we looked at those types of healthcare exposures, we identified that all of our cases had received assisted blood glucose monitoring. So when we also conducted the on-site infection prevention observations, we noted that glucose meters were used for more than one resident, were not disinfected between uses, and that adjustable lancing devices were used for more than one resident. So we instituted control measures, and these included, specific to the facility, using single-use disposable lancets, purchase and use individual glucose meters for each resident, and also vaccinate all susceptible residents. So as a direct result of this investigation, a statewide communication was distributed to all providers in the state about unsafe injection practices related to diabetes care and the use of glucometers. Also, as a result of this outbreak, North Carolina became involved in a national campaign run by the Centers for Disease Control and Prevention in collaboration with partners. And this provides safe injection practices education. So what are safe injection practices? They're a set of measures taken to perform injections in an optimally safe manner for patients, healthcare personnel, and others that might be involved in the process. Many healthcare providers are familiar with injection safety from a healthcare provider safety perspective, but have less familiarity with the concept of injection safety for patient protection. So truly, injection safety for providers and patients are two sides of the same coin. Often, a safer environment for patients is a safer environment for healthcare workers and vice versa. So particularly what we are concerned about with safe injection practices is assuring prevention of transmission of infectious diseases from patient to provider, provider to patient, and also patient to patient. Additionally, we also advocated for laws to be enacted to help prevent dangers to patients. One such law is House Bill 474, which applies to adult care homes in North Carolina. This bill protects adult care home residents by increasing minimum continuing education requirements, training requirements, and competency evaluation requirements. And this law became effective in 2011. CMS now also requires monitoring for and reporting of infection prevention breaches, again, directly related to safe injection practices and safe diabetes care. Specifically, this law requires our Division of Health Services Regulation, which is our sister regulatory agency here in North Carolina, to annually inspect adult care homes for compliance with safe infection prevention activities, requires adult care homes to report suspected outbreaks to public health, and requires increased training and competence evaluation for medication aides and adult care home supervisors. So again, this is the logo for our Safe Injection Practices campaign, also known as the one and only Safe Injection Practices campaign. And again, the purpose of this campaign is to increase awareness about safe injection practices, to train healthcare providers on how to keep injections safe and provide the resources that they can also go to train their colleagues in good, safe injection practices through a Train the Trainer session, which we participate in and we provide 1 to 2 times a year. So transitioning from safe injection practices and hepatitis to multi-drug resistant organisms. I'll pause for a moment to let you read. So what are multi-drug resistant organisms? Multi-drug resistant organisms, or MDROs as we call them, are germs that have become resistant to several kinds of drugs that are normally used to treat them. These bacteria are present and can cause infection in almost any part of the body, including the blood, lungs, urinary tract, wounds, or skin. Symptoms will vary based on the site of infection, and the severity of these infections will depend on the type of bacteria that causes the infection, and again, the site of the body where the infection is. Because multi-drug resistant organisms can be spread from person to person, there is the opportunity for spread within and between facilities by the transfer of patients, either infected or colonized, with a multi-drug resistant organism. Colonized individuals can spread MDROs to others even though they don't have any symptoms. Vulnerable patients, such as those in long-term care settings, may be more likely to contract a multi-drug resistant organism because they're more prone to infection due to increased age and additional comorbidities and healthcare exposures or devices. The resistance to drugs can make these infections, or it can make infections with these organisms difficult to treat, which can also increase associated morbidity, mortality, and the cost of care. For example, mortality increases up to 50%, or mortality rates up to 50% have been reported for bloodstream infections caused by one type of multi-drug resistant organism called carbapenem-resistant Enterobacteriaceae, or CRE, which I'll discuss in a moment. Finally, why do we care? Multi-drug resistant organisms cause approximately 2 million infections in the United States annually, with 23,000 deaths. So listed here on the slide are just a handful of select multi-drug resistant organisms. These include methicillin-resistant Staphylococcus aureus, or MRSA, vancomycin intermediate or resistant Staphylococcus aureus, or vice versa, vancomycin-resistant Enterococcus, or VRE, extended spectrum beta-lactamase, called ESBL, and last but not least, carbapenem-resistant Enterobacteriaceae, or CRE. So CDC has divided multi-drug resistant organism threats into 3 categories: urgent, serious, and concerning. So without intervention, it is actually likely that many of these will shift categories from concerning to serious and serious to urgent. Today, I will actually focus on 2 multi-drug resistant organisms, one in the urgent category, and that would be carbapenem-resistant Enterobacteriaceae, and one in the serious category, extended spectrum beta-lactamase, and that is ESBL. So what is ESBL? ESBL is actually an enzyme that can be produced by gram-negative bacteria. This enzyme makes the bacteria resistant to certain antibiotics. And these are actually kind of the antibiotics of last resource. Bacteria that produce ESBL are called ESBLs, or ESBL producers. These organisms are fairly common in the United States and can be community acquired, similar to MRSA. ESBLs are spread via direct or indirect contact with either infected or colonized patients and contaminated environmental surfaces. Often, they are spread via contaminated healthcare worker hands. So why do we care? What is the public health significance of these organisms? Well, ESBLs are a concern for several reasons. As a multi-drug resistant organism, again, they're difficult to treat. Vulnerable patient populations, like those with a history of long-term care, communal living, receiving home health services or hemodialysis, or a previous history of another antibiotic-resistant organism, are at greatest risk of infection. Often these types of patient populations are transferred between facilities, and lack of communication regarding a patient's MDR status can delay important control measures to prevent the spread. Lack of proper treatment may also cause these organisms to become even more resistant. So in some instances, they may produce another enzyme called a carbapenemase. So that leads us to CRE, carbapenem-resistant Enterobacteriaceae. And if you'll remember back, this is actually considered to be an urgent public health threat by the Centers for Disease Control. So these organisms are resistant to nearly all antibiotics. And I just mentioned the development of an enzyme called carbapenemase, and I've just listed a couple of those organisms on this slide. I do not expect you to know what they are, but they are just listed here for your information. So as far as the public health significance of these organisms, so in addition to being difficult to treat, infections caused by these organisms are also associated with high mortality. You may remember that I mentioned a 50% mortality rate with an invasive case of CRE. So again, it can cause up to 50% mortality with an invasive infection. Again, some of these CRE can easily transfer resistance among other bacteria and gram-negative organisms. And last but not least, they cause approximately 9,000 healthcare-associated infections each year. So I'll move on to another investigation that was conducted. So on April 21st, 2017, a Friday, of course, we were notified by a local health department of an increase in the number of infections caused by a specific multi-drug resistant organism among patients admitted to a local hospital between these dates listed, October 16th, 2016, and April 13th, 2017. The majority of these cases were residents of 3 long-term care facilities in one county. We assisted the local health department to coordinate an investigation to assess infection prevention practices among these long-term care facilities, and also to prevent further spread of the disease between and inside these healthcare facilities. So 4 cases had actually been discussed on Friday, but on Monday morning when we arrived in the office, over 40 positive laboratories were waiting for us to review. So going back to the control measures, we instituted some initial control measures, and these included using gown and gloves for direct care of patients infected or colonized with these multi-drug resistant organisms, scheduling patients with these multi-drug resistant organisms, scheduling those patients with ancillary services such as occupational therapy or physical therapy at the end of the day to prevent opportunities for transmission from occurring. And also, last but not least, certainly not least, hand hygiene, ensuring hand hygiene was performed, covering all open wounds with a clean, dry dressing, and assuring that incontinent patients, their incontinence is contained, especially when they leave their rooms. So we also conducted several on-site visits to these facilities. Major findings from these investigations included inconsistent hand hygiene. Again, not using appropriate hand hygiene between patients and then either before or following patient care. Inappropriate wound care, and this included reusing scissors on different patients, and then also interruptions in flow from clean to dirty. So typically when we conduct wound care on patients, we move from clean to dirty. And we saw a lot of cross-contamination of moving back and forth. Occupational therapy and physical therapy. Contact precautions were not adequately maintained, and there was also lack of dedicated equipment. So if you have a patient with a multi-drug resistant organism, you want to assure that you have dedicated medical equipment as much as possible to that specific patient. Again, because we know that these organisms can live on medical devices, can live on the surfaces for a period of time. We also identified that contact precautions were implemented to varying degrees, meaning that some people adhered and some people did not. And then also we observed healthcare workers moving from room to room, or even if roommates were in the same, if 2 patients were in the same room, and one individual was infected with a multi-drug resistant organism and one was not, that they actually moved between those patients using the same pair of gloves. So again, contributing to cross-contamination and transmission of disease. One other thing that we also noted, which is fairly new technology, but the use of touch screens. These screens are also kind of overlooked as a contamination source. And so if you do have touch screens in your facility, it's good to make sure that you have an appropriate cleaning and maintenance policy. We also noted there was a lack of inter-facility notification. So patients were being transferred between facilities, and the communication of their MDRO status was not communicated to the receiving facility. So again, these individuals were not placed on appropriate contact precautions as they should have been, and they served as a source of disease transmission. And going back to outdated policies, so this is making sure that you actually have a policy in place and that it's reviewed on a routine basis, and we actually suggest that you review this annually and update it. So as antimicrobial resistance grows in the United States, we believe we'll begin to hear about more clusters in these types of settings. So it's likely that these types of site visits, such as conducted and reviewed here, will only increase. So this is a list of some of the control measures, in addition to the ones that I discussed as far as the case finding was concerned, that we instituted. Control measures for these organisms are certainly multifactorial. And I will review not all of these, but I'll review most of these listed here. So staff education is key, making sure that staff understand what a multi-drug resistant organism is and the role that they play in preventing transmission. So it's imperative that in-service education on infection prevention be provided to your staff members on a routine basis. Again, we actually recommend annually. And also, as far as staff education is concerned, here in North Carolina, we actually have an administrative code rule specific to infection prevention, and that is listed here on the slide. We call it 0206. And that actually means that one staff member in charge of infection prevention for each facility must have received this infection prevention training. So they must attend this course called 0206. Another control measure that was instituted is cohorting of infected residents. So this is actually the placement, as much as possible, placement of these residents who are infected or colonized with the same multi-drug resistant organism in the same location. We recognize that within long-term care facilities, this is a bit of a unique environment because a long-term care facility is a patient's home. And so we need to be very aware of that. But as much as possible, if we can cohort these individuals, again, to prevent the risk of transmission to non-affected residents. We also recommend dedicating non-disposable equipment that cannot be adequately cleaned or disinfected, such as those cloth gait belts that are used during physical therapy to individual patients with a multi-drug resistant organism. And as I mentioned previously, if a patient with a multi-drug resistant organism has therapy in a group therapy room, schedule that patient at the end of the day in order to appropriately terminally clean the equipment and minimize the potential for disease transmission. Also, clean the rooms of these patients after completing the cleaning of other rooms when feasible. So this does actually involve additional education of the environmental services personnel, and we realize that sometimes that can be a barrier. When single patient rooms are available, we would give priority to those persons identified to have a multi-drug resistant organism as they have the highest possibility risk of transmission. And when they're not available, again, cohorting, as I've previously mentioned, cohort those patients with the same multi-drug resistant organism in the same room. So contact precautions. So this involves the use of gown and gloves for direct patient care, either of patients infected or colonized with a multi-drug resistant organism. Place patients colonized or infected with a multi-drug resistant organism on contact precautions. And again, recognizing that these long-term care settings are the patient's homes. Sometimes there actually are some adjustments that can be made with the use of contact precautions. But sometimes when patients can actually become at a lower risk for transmission, we can actually de-escalate the contact precautions and stop them. But contact precautions is to be implemented, especially with these high risk, the ESBL or the CRE, which I previously talked about, that have a high mortality rate. We do recommend institution of contact precautions, and that includes making sure that hands are cleaned appropriately before and after patient contact. Clean those hands with either soap and water if they're visibly soiled or an alcohol-based hand rub. And also to wear gown when providing direct patient care, and also to wear gloves when providing direct patient care. And to put on the gown and gloves before you enter the room and take them off before you exit the room. So I can't emphasize hand hygiene enough. I've listed here on the slide the 5 moments of hand hygiene, and this is actually used, I think, internationally. It just tells you when you should conduct hand hygiene. Again, before touching a patient, before conducting a procedure, after touching a patient, after a body fluid exposure risk, and after touching a patient's surroundings. And as much as possible, increase the availability of hand hygiene agents. Both in the halls, consider placing hand hygiene agents on carts containing personal protective equipment used for contact precautions. And I briefly talked about environmental services. So again, they play a key role in preventing disease transmission. Notify environmental services of those rooms housing patients with a multi-drug resistant organism. Conduct frequent cleaning of those high-touch surfaces, including the bed rails in the rooms with a recommended EPA, Environmental Protection Agency registered disinfectant. And when feasible, clean the rooms of these patients last. So notify transferring agencies and facilities if a patient is infected or colonized with a multi-drug resistant organism. So I think we can all agree that communication between healthcare facilities during patient transfer and discharge is useful. It can communicate the patient's status and needs, as well as the appropriate care plan. It is actually also required by CMS under the reform of requirements for long-term care facilities. And they actually have a proposed revision for acute care hospitals as well. This is specifically beneficial regarding multi-drug resistant organisms because MDROs can cause deadly infections in patients and residents, and they can be costly for healthcare facilities and patients. So communicating the status of MDRO in residents during transfer can prevent the spread of multi-drug resistant organisms between and within healthcare settings, thereby promoting patient safety and decreasing costs. The North Carolina Division of Public Health has actually created an interfacility transfer form, and it does have several benefits. It actually offers a standardized format for interfacility communication of patient MDR status during transfer. The form can also serve as a checklist for what information should be communicated when preparing for transfers or discharges and at the time of transfer and discharge. And it also complies with the CMS reform of requirements for long-term care facilities. And it actually can be found here on our website. So moving back to policies and procedures, it's vital that you have a written infection prevention plan that is reviewed annually. Staff competencies should be included and documented to include re-education on hand hygiene, personal protective equipment, and adherence to contact precautions. Another element that I have not mentioned yet, but is required by law, is the enrollment of the on-site staff member in charge of infection prevention into the 0206 infection prevention course. And I did briefly mention it, but I did not show you that law. So in summary, for this outbreak that occurred, we ended up with 83 cases over a 13-month period of time. So with multi-drug resistant organisms, early detection and aggressive implementation of control measures are key to prevention and control. So lastly, why should you involve public health? I'm hoping that this presentation actually will indicate that we actually can provide communicable disease and infection prevention expertise and experience. I think we're uniquely qualified to assess the patient risk. And these are pretty complex problems, and so we don't expect you to deal with any of them on your own. Each of these organisms involve threats to the public's health. And last but not least, it's our job. So I've left you here with some resources on the slide, definitely not comprehensive, but I've tried to give you a highlight and a flavor of resources that are available to you. Thank you.
Thank you so much, Jennifer, for that enlightening presentation. We're very tight on time. We currently have no questions in the queue, but we could take a couple if anyone needed to call in. Just unmute your phone, or you can type in the chat box. So we will plan to post the video on the website and the slide deck also at a later date. We thank you once again for joining us today. You have a brief evaluation that will be sent to you where you'll be able to print a certificate of attendance. Okay, we do have, they want to see the reference screen again, and then what type of contact precautions are required for ESBL if the patient has a catheter.
So contact precautions are still to be used for physical therapy, whether that physical therapy is provided in the patient room or that physical therapy is provided in a group room. So that would not change the level of precautions if the patient has a catheter. So it would still be contact precautions.
For this presentation, for this live presentation, we will not be providing CEU credit. However, we do plan at some point to apply for credit for the video. And on our future webinars, we have applied for CE credit.
So I'm seeing a comment on here about sample policies for the care of respiratory care equipment. I am going to surmise that that will be, that refers to Legionella. And I would actually say that in regards to respiratory care equipment, there are policies in place that provide appropriate care for respiratory care equipment, and one of those is actually to not use tap water and to follow the manufacturer guidelines for use and care of that respiratory equipment.
So there is not CE credit for this live webinar, but we hope to be able to provide that at a later date after the video is posted. And we are applying for CE credit for our future webinars, which will be offered the third Thursday each month. Our next webinar will be in June, and it will be about reading these multi-drug resistant organism culture reports. So we thank you again. There will be an email alert sent out when the webinar slides are posted on the website and when the webinar is available. We hope that you'll take this information that you've learned today and continue to grow your infection control program and provide safe care for your residents. Another question, Jennifer?
So sterile water versus distilled water from CPAP and BiPAP. Again, my recommendation is to follow the manufacturer guidelines for the care of that equipment.
There was a question about isolation for ESBL, I believe.
So I'm not seeing the specific question about isolation for ESBL, but again, that would be contact precautions. That is a multi-drug resistant organism and it's spread via contact. And so we would recommend contact precautions and the use of PPE according to the situation. So that would be gown and gloves. And then if you do expect exposure to mucous membranes, then also wear a mask and protect your nose, your mouth, and then as in routine care, if you expect exposure to your eyes, then also use eye protection.
There is a question also about, will the webinar be available if we missed it just now? Yes, we do plan to post it on the website at a later date, and there should be an email sent when that occurs. Okay, there being no further questions, I believe that was the last question. We're going to close out the well, wait a minute, there's one more. What can be done to ensure contact precautions for a very mobile resident?
What can be done to ensure contact precautions for a very mobile resident in a long-term care facility with C. diff? So this patient actually we need to make sure that the incontinence is contained. So that's most important. So a patient with active C. diff, if they have active diarrhea, then their mobility should be limited. Their incontinence should be contained for them to move about. And they also need to be educated on appropriate hand hygiene and self-care.
Okay, that is the end of our questions and our time is up. Thank you so much for attending.